Namaste. Welcome to Mimamsa. My name is Manasa Manjunath. Today we have a very special guest. Dr. Parikshit Tank has joined us to kick off a series on women's health. Now, before we go into the details, I just wanted to give a quick introduction to women's health and why we are doing this podcast series at all. Women's health has always been very close to me because, as a woman myself, this is something that concerns me. But this is something that I have noticed that not many women are aware of what is going on with their bodies. There is a significant difference between men and women, and especially when it comes to reproductive health, not many women are equipped with the knowledge that they deserve to be. We all know that sex education does not have a very high priority across the world, I would say, in our country as well. And my intention with this series is mostly to make sure or to help women understand their bodies better, to learn a little more about my own body in a way, because the last I learned about women's reproductive health was in 7th standard or 10th standard, and that's about 15 years ago now. And not just that, I also hope to start off and kick off a conversation in your own drawing rooms, in your own friends' circles about women's health, so that we can break this taboo that is there. So we will be discussing everything from menarche, menstruation, menopause, infertility today. Maybe we'll move on to breast cancer and any other illness that affects women. If this is something that is important to you, if you have any questions, please feel free to put down the comments in the video below. Write to me. I will leave my contact details below. Any questions, any topics that you can think of that we don't cover, we will be very happy to address that. So to kick off today's topic, infertility, I have Dr. Tank here with me. Dr. Tank, first of all, thank you very, very much for making it possible. I know you are taking time out of a very, very busy schedule to be with us here today and to talk to us. Now, I'd like to introduce Dr. Tank a little bit. Uh, so Dr. Tank has been in this field for the last 20 years. He is an obstetrician, gynecologist, and a fertility specialist. He practices in Mumbai, and he does fertility care consultation in about 15 different centers across the country. He is a very recognized person in this field and has many peer-reviewed publications to his name. And thank you so much, Dr. Tank, for being here today.
It's my pleasure, Mansa, and I firmly believe that the goals that you set out in your series to educate, to inform, to initiate discussions. I strongly believe in all these in the very broad sense. So all the best to you for this series, and I'm looking forward to the next 45 minutes to an hour of discussion with you.
My pleasure as well to have you here, Dr. Tank. Now, I wanted to start off with a very, I guess, basic question that everybody has. Why infertility? What was the reason you got into this field?
So, as an obstetrician, it's not only enough to just bring babies out into the world crying happily. Sometimes you've got to go to the root of the problem, as they say. And we used to see a number of women when we were trainees. At that time, there wasn't anything much that we could offer these couples who are trying to become pregnant. So that's probably related to the infrastructure, the type of environment in which we train. So that was like a bit of a gray area, which never got completely covered. When I was a trainee. So there was a natural intrigue, there was a natural curiosity as to what more can we do. Things like menstrual problems, surgeries, cancers. Well, we saw a lot of that. We saw a lot of pregnancy-related problems, how to tackle them, how to deal with them. But this was something that wasn't very clearly dealt with. It wasn't so commonly treated either. So that was definitely an impetus for me. to delve into this subject a little more deeply. And I liked the subject. I enjoyed practicing this part of gynecology. That's how I'm here today.
I think it's a very noble goal that you describe. Would you say the situation has changed since you started practicing because you have been in the field for about 20 years now?
Oh, it has changed beyond anything I can look at in healthcare. When I used to, when I used to consult couples right up at the start of my career, I used to have to tell couples there is something called IVF. There's something called an test tube baby treatment. Not all, of course, but quite a few. Today, that's a conversation which I almost never need to have because everyone knows what that is. Everyone is more forthcoming. They are more interested in being proactive as far as fertility treatment is concerned. And usually, I spend quite a bit of time telling couples that you probably don't need any treatment at this point. So it's kind of come a whole circle, when people they didn't know anything about it at all, to a little more, tempering effect that we need to add in today's time. So yes, a lot of changes, lot of new technology, lot of useful technology, and some which is not that useful. So yes, this field is really marching along.
That's very good to hear. And I think with that, it's a very good initiation to just dive into the topic itself. Now, infertility is not something that is really spoken about. I didn't hear about it. I only know about it because we had a family friend who had infertility problems, but that was very long ago. And I do remember at that time, maybe about 15 to 20 years ago, this couple had to go to all the way to Mumbai to get treatment. Of course, that has changed, as you say, and that is a very good change that is coming in. Now, you mentioned that there are couples coming in now where you have to tell you don't need the treatment. So let's start off with, when would you say that a couple would need to seek medical advice if they are not able to conceive?
Yeah, I think this is an excellent place to start the discussion about fertility care. Uh, Typically, textbooks would define that somebody has a fertility issue when a couple has been trying for 1 year. They are having intercourse regularly, and there has been no protection. I mean, they are not using contraception. Yet, after this 1 year, the couple has not conceived. That is typically how subfertility is defined, or infertility, if you would like to call it. But I think we shouldn't get bogged down by very specific time frames. It all depends to some extent on what is the profile this couple is having. If it's, say, for example, a 38, 40-year-old woman who is married and they have been trying for children for 6 months but not conceiving, I would be interested in evaluating this couple before that 1 year mark is over. Whereas if it's a younger couple, no apparent problems, everything is going well, I might give them a bit of a leeway and tell them that, okay, you've got plenty of time. So just wait on and see what happens. Let nature take care of the situation. So even though typically we say 1 year, but that's a bit flexible as far as when couples should seek attention.
Okay. So this is something when I was doing my research, I also came across so that I could ask you questions. So when you say that 1 year or 6 months, like you said, depending upon the age or the profile of the couple itself, this is assuming that it also is taking into account when the couple is having intercourse, assuming that they time it according to your ovulation, right?
Right. So typically, if you consider a 28 to 30-day cycle, the fertile period is something which is classically described as day 11 or day 10 to day 17. That's the time in which the couple should have intercourse, and that is the time when the chances of having a pregnancy are maximum. However, there's a small caveat which I would like to add over here. One, every couple does not have to do like a calendar and then schedule intercourse and so on and so forth. If we look at a young, healthy couple you know, who may have intercourse twice or thrice in a week, and if they try it every week, well, that's more than enough for a pregnancy to happen. So, even though we talk about fertility period or the time in the menstrual cycle when the fertility is at a peak, it's not necessarily helpful to track days. Sometimes it actually becomes a bit stressful for couples to have intercourse on pre-planned days. It makes them a little bit nervous. They feel, the stress of performance, anxiety comes up, a few disagreements here and there, and then we are completely off track from intercourse. So, yes, technically day 10 to day 17, but every couple need not count.
Okay, I think that was good to clarify. So I'll move on to the next to my next question. We already spoke about age, where you said that the profile is very important. What are the different factors that you consider in a profile? Age is, of course, one thing that you've already mentioned. What else do you take into account?
So, age, that too of the woman, that is the primary factor which decides, how soon I need to see this couple, how aggressively do I need to investigate, what kind of treatment I should offer, what's the prognosis of the treatment. It all depends very, very strongly and correlates very closely with the woman's age. The other things what are important in the profile, especially for a woman, are her menstrual cycle. Whether it's a regular cycle, is the menstrual period normal? Has it changed drastically in recent times? Whether she's had any surgeries on the uterus, ovaries, tubes, any pelvic surgeries or any abdominal surgeries, and of course, past medical events, for example, a history of tuberculosis or a history of pelvic inflammatory disease. All these would negatively affect what the fertility profile is likely to be. Now, even though we talk about all these factors on historical evaluation, that means simply by asking the couple, or on examination, unfortunately, they will identify only about a quarter at best of couples who may have problems. So, yes, profile is important. It gives a general direction to what and how to approach this couple with, but ultimately, it does rest quite largely on investigations and tests. So that's the important thing as far as profile of the couple is concerned.
Okay, so before we get into the tests that you would do or the investigations that you would take up, there are, I think, some common questions which are asked about infertility when it comes to the profile part of it.
Yeah.
One of the key things being what you have already mentioned, being menstrual health. Now, of course, normal menstrual health or normal menstrual cycle you already mentioned, but we also know there are some problems like PCOS and endometriosis. What kind of an effect or how does this affect the infertility part of it?
So we have to understand that the menstrual cycle is ultimately a reflection of egg making and hormone production. Every month, when the menstruation occurs, the woman starts generating one growing egg in her ovary. And this growing egg causes certain hormones to get generated, leading to changes in the uterus and ultimately a period. So, if we look at just the menstrual profile, it's actually an indirect information, or we can kind of get some indication about what is happening with ovulation, what is her hormonal profile like. So PCOS is typically one of the very common things what we are looking at in the world today, really, and it disturbs the menstrual cycle because there's no ovulation, there's no egg growth. Even if an egg grows, sometimes it doesn't rupture, doesn't produce enough hormones, and that leads to situations where there's a prolonged cycle. Sometimes the cycle does not even come unless the woman takes certain type of medications. So yes, this would definitely affect the fertility chances. The second condition that you mentioned is endometriosis, and this is something which will cause immense pain, usually just around the days when the woman is going to menstruate. And this again has negative connotations for her fertility because of certain mechanical factors, in the sense that endometriosis not only affects the ovaries and ovulation, but it also affects the tubes. It can block the tubes off. It can create a hostile environment in the uterus and in the pelvis for pregnancy to occur. And yes, these are the two common menstrual problems which correlate closely with the chances of fertility or infertility.
That's good to know. And I think this might be a question that may come up later, or at least it's a question that occurs to me. Would you say, or would you recommend that someone who has these problems and wants to conceive comes to you earlier, maybe, than you would tell other patients to?
Yes, I think it's important for them to consult a physician fairly early. It's not as if we have to do something immediately, but at least the woman gets a sense or a direction in which her reproductive health is likely to move. So yes, I think there is value in an early consultation.
Okay. Dr. Tang, let's now move on to what you mentioned earlier, where you said that you will evaluate couples for infertility and you take some tests, you conduct tests. Can you give me a little bit of a brief overview? What do you do? What do you look at?
Right. So it's very important to understand that subfertility is a couple's issue. It's not only a woman's issue, and there is equal partnership in terms of causes for not becoming pregnant as well as treatments. So the man has to be investigated first, because it's very easy to investigate the man, and then you go on and investigate the woman. So the tests that typically would be necessary before really coming to any sort of direction or conclusion are a semen analysis for the man, an ultrasound for the woman, some basic blood tests to look at the hormonal levels and profile that the woman has, and certain tests which are directed towards her overall health, because ultimately an infertility consultation is also an excellent opportunity to optimize her health for the pregnancy which is going to follow. So I would do like a blood count, blood sugar levels, screening for infections, and look at her health in toto, rather than only at the infertility test. So that's where we would begin, and usually, if these tests are all right, then a couple may be asked to just try on their own for a while, or they are given some basic therapy. If a certain time elapses and the treatment has not worked, then one would recommend a tubal test. Now, that's important to establish whether the tubes in the woman are both open, one is open, or both are blocked. And there are a number of ways in which we can find this out. we can do something called an HSG, which is an X-ray, uh, which tells us after injection of the dye whether both the tubes are being seen and the dye is spilling out from both sides. That's probably the simplest test. There is an ultrasound test which is very similar to the HSG. Again, goes with the same type of process. We inject something into the uterus and do the ultrasound along with, and see whether the fluid or the dye is coming out from both the tubes. And in some cases, where there is a suspicion that there might be some pelvic disease which I would need to correct, I would offer these couples a laparoscopy. So, a laparoscopy is a surgery actually, which is performed under a general anesthesia. So, that's reserved only for a few couples where the woman, say, coincidentally has a cyst or she has a fibroid which needs to be removed, so on and so forth. In modern fertility care practice, the laparoscopy is no longer looked upon as the primary test for tubal patency. So, just to enumerate the tests again: a semen analysis for the man, an ultrasound, blood tests, and tubal tests for the woman. These are the ones which will, kind of provide us with a lot of information, a lot of useful direction in which this couple would then be taken forward.
I want to talk a little bit about the tests that you do for the men before we move on to the women, because I think a very popular English show has tackled the issue of infertility. In Friends, I remember that Monica and Chandler go through infertility treatment, and I think one of the things that they mention is sperm mobility and sperm count. Can you just give us a brief overview of what do you look at in these sperm samples?
So the first thing is I mean, as I mentioned, that this is the real starting point of evaluating a couple for fertility issues. The man is given instructions to have an abstinence of 4 days and then go to the fertility clinic or lab and give a semen sample by masturbation. This sample is then analyzed, and a number of physical characteristics, microscopic characteristics, chemical levels are looked at to evaluate what is the fertility potential of the semen sample. The most important things in this analysis are the sperm count, the sperm motility, and the sperm morphology. Count is very obvious. It's self-explanatory as to how many sperms are there in this semen sample, and that is usually expressed as a certain number of millions per milliliter. So you typically have samples where the cutoff is 15 million per ml as the bare minimum what's needed for fertility. Do men become pregnant with lower counts? Yes, of course, all the time. I mean, we see these things happening very routinely, but these are certain parameters that we look at to assess what is the prognosis or how fertile is this semen. So the sperm count should be 15 million per ml or more. There's no upper limit really. I mean, but typically, it kind of caps off at about 100 million or so. That's parameter number one. The second is motility. Now, motility is important and it needs to also be graded. It's not enough for a sperm to be just motile and be stuck in one place. Even this is motility, but the sperm needs to be forward progressively motile, quite like what human beings also should be: forward progressive and motile. So the number of sperms which exhibit this kind of feature of forward progressive motility should be at least 30% of all the sperms. And the last parameter that I spoke about was sperm morphology. That means what does that sperm structure look like when it is subjected to a very intense analysis of its structure. The modern criteria is that only 5% of all the sperms which are there in a semen sample need to be normal looking to be adequately fertile. So those are the cutoffs and those are the parameters that we look at in a semen analysis.
Thank you, Dr. Tang. That was very informative. I think a lot of people would have learned a lot of things with that. And let's now dive into the women's fertility or the test that you do there. You mentioned first you do a ultrasound, you do a blood test, and then you also look at the tubes. So the tubes you already explained that you want to check for any blockages. What do you look for in the ultrasound? I'm assuming you then look at the uterus when you're looking at the ultrasound.
Absolutely right. An ultrasound is really, in modern fertility practice, we call it an extension of the clinical examination. It's no longer some kind of exotic test. It's really a part of almost every clinic visit. And what we are looking at is very grossly is the structure of the uterus. Where is the inner lining or the endometrium of the uterus placed? Is it central or is it displaced? Are there any abnormal growths in the uterus like a fibroid or in the lining of the uterus, which is called a polyp? Is it too thickened? Is the wall abnormal? Sometimes unusual things like the uterus being split in two, which is called a septum, or completely two uteri, which may occasionally be there in some women. So these are the main features what we are looking at on ultrasound at the uterus. And the other focus, of course, is to look at the ovaries, to look at what is their size, how many small eggs, or what's also called as antral follicles. That means eggs which have the ability to grow when certain type of conditions are met. How many of those are there, which again is an indirect indicator of the egg producing capacity. And we try to look for any abnormal growths in the ovary or related to the tube. So the ultrasound is my friend. I mean, I love it, and it really helps to make quick decisions to reach conclusions much faster than any other test, really. So ultrasound is something which most fertility clinicians will practice on their own, and they'll do this test usually at at initial contact itself.
Is this ultrasound done vaginally or is it done over the stomach?
So the transvaginal ultrasound gives much more information than a transabdominal ultrasound. So, barring an exception where a woman refuses or is extremely uncomfortable with an internal scan, uh, that's the route to go, really, because the type of images, the type of information that can be got from a transvaginal scan is not matchable by a transabdominal scan.
Okay. Now, I found one thing that you mentioned very interesting. You spoke about a septum in the uterus, or you mentioned there could also be two uteri. Um,
Yeah.
when we talk about two uteri, is it possible that you have two different periods or a shorter cycle?
No.
No.
Uh, Even if a woman has two uteri, the period is governed by the egg making and the
Mhm.
hormone production. So these would happen at the same time for both the uteri.
Okay.
So it would be just the one period.
Okay, that's very, very interesting. Now, Dr. Tank, I want to go a little more into depth. Now that let's assume that you have a couple which has come in and you have done all these tests. What there are, of course, very different type of fertility treatments. when do you start saying that a couple should look at a fertility treatment, and what kind of different treatments do you offer, and what are the basis for these treatments when you suggest one to a couple?
Right. So again, what makes our decisions about the type of treatments, whether to offer treatment or not, is the profile. I go back to it again and again, but there's nothing which is as important as the woman's age in deciding what to do. The second thing, which is also very, very important, is the trying time. How long has this couple been trying for a pregnancy? Has it been 6 months and they are just maybe a little bit anxious, or has it been a good 5 years and they've still not gotten pregnant? So that's the second parameter which will help me to decide the way forward. And the third is the treatments which have already been done. So if a couple has already had a certain type of treatment, it's usually not very productive to just repeat the same story again and again. You've got to go ahead. So that's how we come to a decision about whether to treat and what type of treatment that we are going to do. So what are the, very broadly speaking, what treatments can we do to help couples get pregnant? One, and I believe very strongly in this, is education. Sometimes you need to just go a little bit below the surface and check what this couple is probably doing in the bedroom. Uh, in practice, we come across all sorts of seemingly funny situations. They seem funny to us, but they are just a reflection of the lack of information which is out there. So sometimes couples will have intercourse just once a month, and they would consider that as adequate in the form of a trial. Sometimes intercourse is not really happening. I mean, there's no penetration, and the penis is simply at the opening of the vagina. There's no deposition of sperm into the vaginal tract, and that's where we need to be careful of not missing things. Because if you miss all this in the initial contact, then kind of reviewing it back and trying to go back to it later is probably it's not going to happen ever, and this couple will be left with that misinformation forever. So the first
Yeah.
level of treatment is really education, information, and some patience. The second level is inducing ovulation with oral medications or tablets. And then we do an ultrasound to check how the egg is growing. And when the egg is close to ovulation, we advise couples that, okay, now we are approaching that, peak fertility period, and go ahead, have intercourse on certain days of the cycle. So that's a very, very basic level of treatment. Then we have stimulating the ovaries to make more than one egg at a time. So typically 2 or 3 eggs, which are grown together by giving injections either every day or in combination with tablets. And along with that, commonly IUI or intrauterine insemination is offered. So the treatment is a cycle of injections in the first few days, starting in the first few days of the period, on say second or third day, going on for about 8 or 10 days, evaluating by ultrasound regarding the egg growth. And when the eggs are ready, we trigger the release by giving one injection called HCG, and then we do this procedure of IUI. Now, what exactly is IUI? It's a process where the man gives a semen sample, the best sperms are selected from it, and a very small pellet of these active motile sperms is made in the lab. You remove all the impurities, the dead cells, etc., and then these cells which are selected, the sperms which are selected, are placed directly into the woman's uterus. So this is of course a clinic procedure, doesn't require anesthesia, etc. Life isn't really disrupted very heavily. So this treatment of giving injections and then doing IUI, it helps on two fronts. One, it increases the number of eggs which are available for fertilization, and two, it potentiates sperms, brings them closer to the egg, and hopefully fertilization is possible to a greater extent than otherwise. So this is like an intermediate step in the treatment. And then of course we have IVF, which is commonly called as test tube baby treatment, though the correct technical name is assisted reproductive techniques. And then there's a whole gamut of what we can do. But very briefly, what exactly is IVF? It's a process where we give injections to grow multiple eggs in the woman's ovaries, remove them via a sonographic procedure, join these eggs with the husband's sperm, get the embryo prepared in the lab, and then transfer these embryos back into the woman's uterus. So, in a nutshell, it is essentially achieving what fertilization process should occur in the body on its own. We are doing it outside in the lab, and that's interestingly how the word IVF also comes up. It's in vitro. Vitro is glass, as we all know, and we are achieving fertilization in a glass dish. That's how the name came up, IVF. So those are broadly the types of treatments that we can offer couples. IVF, of course, has a lot of variations in terms of intrinsic techniques, how fertilization is done, how sperms are retrieved in case a man cannot produce a semen sample, so on and so forth. But I think that's a completely small subset, really, which needs all those subheadings, as one would say. These are the broad outlines.
Okay. You've described now a complete spectrum where you go through many different procedures, depending, like you said, on the profile of the couple. In your experience, what would you say is the percentage that you have to employ for each procedure? For example, for all the couples that come in, how much of the couple's problems, so to say, are solved by just education? How much is solved, like you said, about the second, the intermediary part with IUI, and how many have to move on to the IVF? Do we have any kind of statistics available on this?
Yes, we do fairly. I mean, there are good papers which have been published on this particular topic as to which fertility treatment benefits how many people. And if you look at level one, which is education, information, patience, and time, that often sorts out about maybe 20-25% of people get sorted out over there. Another 10-20% will benefit from the most basic kind of fertility treatment. So you're left with half the couples that you started with. Then a huge chunk goes through IUI, and that usually gives pretty good results. And then you're left with 10-20% who need IVF. But now, I must confess that this is very different in my own clinic, because naturally one would see a little bit of a biased kind of a view, because you often get reference. So they would be couples who kind of already been there, done that. They've been through the whole gamut, and then they're at the end of their tether, so to say. So it would, of course, vary from clinic to clinic, but broadly speaking, these are the outlines when we look at a population kind of a figures.
I have another question. Let's say a couple comes to you. How long does this process take for with the initial tests, investigations, up until you suggest a treatment to them? Of course, I'm assuming that the education would be the shortest amount of time, but with IUI and IVF, it would go on for a lot longer.
Right.
So, what approximately time periods would we be talking about?
So let's imagine a situation where the education, information, patience, and time have already been dealt with. And typically, evaluation shouldn't take more than the particular cycle in which the couple has come to you. So it's the tests get done in that month, and then we see couples again once the test reports are in, and plan what we can do in the subsequent period, in the subsequent cycle. One rule of thumb, which I should mention, is that any sort of fertility treatment, I mean, whether it's a basic treatment, whether it's intermediate or advanced assisted reproduction, the best chances are in the first 4 or 5 attempts. So even though it may be attractive to persist with certain very simple treatments for much beyond those 4 or 5 attempts, practically it doesn't add much value for this couple, because whoever is going to get pregnant from a particular treatment will get pregnant in the first few attempts. After that, it's just a repetition which does not necessarily yield any benefits. So I mean, if we take a situation where the couple would not take even a month's break, and that would be extremely unusual, uh, their range of treatments would be kind of complete in, say, 12 to 15 months, really.
Okay, so I would say that maybe just how much you would have to try and wait. So it's the same amount of time again that is added on to it. Um, Now, I have another question, and this is also an audience question. Um, you mentioned about IUI, you mentioned about injections or oral medication that you would provide to increase the egg production. Uh, that means that there are more eggs available. So Karan asks, is it true that chances of couples having twins or multiple babies are higher when they get fertility treatment?
You're absolutely right, Karan. And this is one of the things that we try to minimize when we are doing fertility treatments. Uh, Even though multiple pregnancies, twins, when they grow a little older, they look cute and so on and so forth. But these pregnancies aren't easy to handle for the woman. It's a tough time, in the initial part after the delivery, and of course a whole range of obstetric problems which can crop up in multiple pregnancies. So yes, you're absolutely right. The chance of having twins is higher. For example, if I'm doing an injection plus IUI treatment, the chance of having a twin pregnancy goes from 1%, which is the baseline, to approximately 4 to 5%. And if I'm doing IVF, then that chance goes up even more to about 10% or so. So that's the kind of exponential rise in the chances of having a twin pregnancy as treatment gets more complex and you progress along the ladder.
So now I want to talk about something else. I think, Dr. Tank, you have covered the different treatments that you offer. You've covered how you evaluate your patients. Um, I think this is the emotional or the psychological aspect. Now we are a baby obsessed country. Within 6 months into a marriage or a wedding, the bride is asked, "Okay, when are we hearing good news?" Um, and here I speak from personal experience. But in a country like this, where baby talk is a big deal and everybody talks about it, being not able to conceive is, of course, not something people discuss anyway. But when it comes coupled with this, it can cause emotional trauma, it can cause psychological trauma. And when the couple is taking time to conceive, or whether they're taking infertility treatment, I'm assuming that this is a very emotionally stressful, psychologically stressful time. Um, Do you also recommend any kind of psychological support, emotional support to the couple which is going through treatment?
Yes, I mean, you mentioned that what are the factors which decide the type of treatments that you offer. And I must say that the couple's choices are also very important, and they are often driven by exactly what you mentioned, the time frame in which they have to produce results. So yes, that's a very important factor. It does add to stress. And what sort of support or psychological help is to be offered? Well, it can be informal. It can be even at the time of consultation, just listening to what their experience has been and what is bothering them, or it may be something much more formal in the form of a proper assessment, counseling, relaxation techniques. And I must say, I'm very fortunate in this regard that my wife is a psychiatrist and she's a therapist as well. And she's kind of tuned in to what to expect when I refer these couples to her. So, yes, but of course, it's not as if everybody needs some kind of therapy. Some do, and it's important for us to identify who these couples are and help them along.
I think that's very nice, and I think it's very helpful for you also when your wife is a therapist to send you to have an immediate referral for your patients. Now, Dr. Tank, we've I think covered a lot of different things. I would like to move on to the last bit of it, where I want to talk about myths associated with infertility. Before we move on, would you like to add anything that we've maybe missed out on?
Just a quick word about why are treatments progressive? Why can't we just do the treatment which has the maximum success rate when it comes
Yeah.
to infertility treatment? Why don't we approach the problem like that? Well, because yes, even though fertility treatments, say for example IVF, typically the live birth rates are somewhere around 40%, which compared to a basic treatment is much, much more. A basic treatment would give you something like 7, 8, 10%, and this is 40%. But there are certain downsides to fertility treatments as we advance. And one which Karan brought up was the chance of having multiple pregnancy. The
Mhm.
second is the exposure to hormones, and third is the expense, because in India, most of these expenses are going to be met out of pocket. There's no insurance coverage. So these are the reasons why fertility treatment is progressive, why we don't, kind of hammer every nail with the biggest hammer that we have. Even though it would, get the nail into the wood, it would also cause some collateral damage. So we want to keep that collateral damage to a minimum. So that's the only other aspect which I thought I should just quickly touch upon before we go on to the myths. Please go
Uh,
on.
That's a very good point. You mentioned hormones coming into play. You mentioned the expense being a factor. I think one thing we've not covered is, are there any side effects of these treatments that we should consider?
Yes, of course, there are side effects with everything. I mean, even if you take a simple tablet of paracetamol, you
Yes.
can land up with gastritis. It's just the question of how frequently and how serious are these problems and whether you can mitigate them or not. So, when we talk about side effects of hormonal therapy, some are very transient. I mean, they are temporary, and they would be mild disturbances in mood, a bit of gastrointestinal features, feeling bloated, so on and so forth. Sometimes we use vaginal route to administer medications, and there could be an infection or irritation in the vulva or the vagina as a result of these. So these are things which are at the mild end of the spectrum. But you could also have something more serious like ovarian hyperstimulation when we do assisted reproduction or IVF, where too many eggs grow together, and then that could lead to a swelling of the ovaries, fluid accumulating into the abdomen, so on and so forth. Fortunately, now we have methods by which we can avoid this or minimize the risk of this happening. So it's not as common as what we used to see it maybe 15 years back, but yes, the risk does exist. And of course, procedure related. So, for example, if I'm doing an egg retrieval, then there's anesthesia involved there. There is a needle which goes into the pelvis. Once in a while, there can be surgical accidents, accidents related to anesthesia. All these do count in the column of side effects or adverse outcomes as far as fertility treatment is concerned. So yes, it's not all hunky dory there. So we need to weigh and balance going forward.
I think that's a very important point also to drive home to everybody, especially what you said earlier, the point about taking the biggest hammer to nail the nail into the wall or to into the wood. It's important to consider the repercussions or the side effects as well. Um, now, Dr. Tank, let's move into some common myths that are associated with infertility. And when I was going through the internet for my research, there are many, many different myths that I came across. But I'll go with some of the most popular. This one myth you already addressed very early in our session. You said that infertility is a couple's problem. It's not a woman's problem. It is both a man and a woman, and that's why you, of course, test the man first as well for the sperm sample. Now, the second myth is that stress and work are the leading cause of infertility. Would you like to comment on that?
Stress and work are the leading causes of infertility if a couple is so stressed or so busy that they don't have intercourse.
Mhm.
Yeah, then obviously they are contributory factors. But I think the play on stress has been it's been overdone according to me. Uh, does stress contribute to difficult marital situations? Yes, certainly. Does it contribute to less intercourse? Yes, certainly. Does those two things lead to fertility problems? Yes, certainly. But stress by itself, hard to pin down whether that really plays a very, very significant role in the whole infertility community. So
Okay.
I think women should continue working. They shouldn't stop working when they are doing fertility treatments. And sometimes it's just hearing the word stress which makes you even more stressed. When you're given the information that you're stressed and that's why you're not getting pregnant, that doesn't help things at all. So I think it needs to be put into perspective over there.
Okay. I think one other thing that I came across is using the pill can also lead to infertility. How true is this?
No, that's absolutely not true. The pill will affect fertility only in the cycle in which it has been taken. Suppose a couple decides that they want contraception until December 2020 because 2020 has been the least favorite year of all times. If they would start trying in 2021, then well, just don't take the pill in January, and well, fertility is where it was. So, in fact, there are a lot of papers and there's a lot of research which tells us that the pill might actually preserve fertility rather than impairing it. So, absolutely no truth in that rumor or myth that contraceptives affect fertility.
Yeah, I think that it is propagated more so that women lose control again of their
Probably, yeah.
reproductive health. Now, uh, some of these you've already mentioned, I think, where you said that uh, a couple which has intercourse regularly, they can already they do not have to worry about timing the intercourse, and timing intercourse to fertility can lead to more stress and can lead to anxiety of performance, etc. uh, I think one other very common myth is intercourse has to occur in a particular position for there to be conception.
Yeah, again, this is not true. As long as the semen is deposited into the vagina, it really doesn't matter in what posture the couple is, and it does not matter what the woman does afterwards either, because sometimes one hears of couples where the woman will raise her legs or put a couple of pillows under her hips, so on and so forth. Well, all these are harmless, but there's really no need to do all this, because nature has a mechanism by which the most motile sperms in the semen or the ejaculate are already at the very, very first micro drop of semen. So they are going to be retained in the body, and in fact, by the time the pillows are put and the legs are raised, etc., most of those motile sperms are already making their way through the cervix and into the uterus. So all these things don't add much at all to the chances of conception.
I think that's a very nice message to send out for all conceiving couples. Please do not worry too much. As long as you're having regular intercourse. Now, I didn't come across any other myths that I think we should address. I think these were the most popular in the internet based on my research. And I'm also mindful of your time, Dr. Tang, because we are almost reaching the 1 hour mark. So I would like to end the session with one last question for you. What is your advice to couples who are trying to conceive in the broader sense of the term, whether it's couples just starting off on this journey, or whether it's couples who are a little getting a little frustrated from trying for quite some time?
So my few messages. I'm sorry, it's not going to be just one message, but maybe a few bullet points, so to say. One, if you want to become pregnant, keep trying. Don't give up. You may take a break, every now and then, but do persist. Sometimes, things come a little later, but they do come. So that's message number one. Second, keep a broad, kind of a canvas when you're planning your reproductive health. Uh, Even though I said that keep trying, I also would like to add in the same breath that don't get pressurized by external influences to a very large degree. Make up your own minds. Make up your own minds in terms of how you would like to approach the situation, how aggressively you would like to approach it, and whether non-medical options would be suitable for your particular temperament, for your particular environment, for your family. And here I'm talking about adoption because it needs to be considered when we start talking very broadly about the options for completing a family. And the third message is that don't take yourself and the results very seriously, because ultimately this is a part of life. It's not life itself. So, having said those few things, I wish all the couples who are trying the very best in their fertility endeavors.
I think those are very, very lovely messages that you just gave, Dr. Tank. I think it will be very helpful for everybody out there who are considering all the different options available. As you mentioned, adoption is, of course, a very good way to consider adding to someone's family. And it is something I think a lot of younger couples are considering. I have heard of this happening quite often. So thank you very much for that message. And I see that some of our viewers also found this conversation very informative. Uh, there's one more. So I would, at this point, I would like to say thank you so much for taking time out. Thank you for going through all the different all the different procedures that you do, what are the different tests that you do, and guiding, I think, anybody who has any questions about fertility in through this. I think sometimes it can be an overwhelming journey. So you have given us such a beautiful overview. Uh, so I think it will be helpful for a lot of people doing this. Thank you very much for taking the time.
Thank you very much, Mansa, and I wish your series all the very best and keep up the excellent work that you're doing. All the best.
Thank you very much. So, to everybody watching, also, thank you very much for joining us. To anybody who may watch later, thank you for watching. If you have any questions, comments, or anything that you want to share, please leave your comments in the video below. You can also reach Dr. Tank on Twitter. I will add his Twitter handle down below. I will also add my Twitter handle down below. If you want us to discuss any topics in the future, please feel free to let us know. And I will see you on the next podcast. Thank you.